The title of this talk is Managing Uncertainty in Clinical Genomics Toward a Systematic Approach, and I'm pleased to have the opportunity to share my thoughts on this topic. Before I begin, I want to affirm that I have no relevant financial relationships and that this talk reflects my own opinions. The objectives of this talk are to provide a set of conceptual frameworks for understanding the problem of uncertainty in medicine in general, and to outline a systematic approach to managing uncertainty in clinical genomics in particular. Uncertainty is an important problem in medicine in general. It motivates and complicates nearly all clinical activities undertaken by patients as well as clinicians, and the same is true for clinical genomics in particular. Numerous interventions, ranging from genetic and genomic testing to gene editing, are clouded with a variety of different uncertainties. These uncertainties arise from numerous questions, including what are the appropriate populations and indications and goals of different genetic and genomic interventions? What are their benefits and harms? What is their clinical utility? And finally, what are the best and most effective dissemination and implementation strategies for these different interventions? And there are many other questions as well that all give rise to different uncertainties that we struggle with. Given the many different uncertainties that pervade and complicate medicine in general and clinical genomics in particular, the key question is, how do we even begin to deal with these uncertainties? Where do we even start? One approach that I've spent much of my career exploring is to develop conceptual frameworks that can help us bring useful order to this task. Conceptual frameworks can first provide us with orienting maps that can help us understand the phenomenon of uncertainty, including its nature, that is, where does it come from, what's its etiology, what's its anatomical structure, if you will, that is, how does it manifest, what are the different forms and shapes and varieties of uncertainty, what is the natural history of uncertainty, how does it affect people psychologically, and finally, how do we manage uncertainty? How do we evaluate it and actually treat it clinically? Conceptual frameworks can serve as a navigational tool that can help us answer all of these questions and to take a more systematic clinical approach to managing uncertainty. In the rest of this talk, I'm going to focus on developing conceptual frameworks that deal with three main aspects of uncertainty in medicine. First, its nature. Second, its effects, and third, its management, and I'll talk about what each of those different categories means. The first set of frameworks I'll present provide a way of understanding the nature of uncertainty. Specifically, what is its etiology and anatomy? What is it? Where does it come from? And what does it look like? Uncertainty itself has been defined in many different ways. Dictionary definitions, such as this one from the Merriam-Webster dictionary, variously construe uncertainty as a quality and a thing and a state of being, and they use a variety of different adjectives to try to capture its essence. I take the specific view put forth by various different social science scholars that uncertainty is not really a quality or a thing, but it's actually a very particular kind of mental state. Specifically, uncertainty is what psychologists call a metacognition, a product of second order or reflective thinking, or a thinking about our own thinking. Specifically, uncertainty is a metacognition consisting of the conscious awareness of our own ignorance. As such, uncertainty is not equivalent to ignorance itself, but instead it's a form of knowledge. The origins of the metacognition of uncertainty are both psychological and social. Psychologically, it arises from the conscious deliberation provoked by novelty or discrepancy in information. Socially, uncertainty arises from the interaction between different explanatory models of the world, which are transmitted from person to person in the interactions between them. As a metacognitive state, uncertainty has very distinguishable conceptual dimensions that lend a particular anatomical form and shape to the phenomenon. The first dimension is the source of uncertainty, that is, the root causes of the ignorance that one is conscious of. The second dimension is the issue of uncertainty, that is, the substantive topics or questions that represent the objects of one's uncertainty. While the third dimension is the locus of uncertainty, that is, the particular persons in whose minds uncertainty lives and resides. Turning first to the dimension of the source of uncertainty, there are three primary sources of uncertainty: probability, complexity, and ambiguity, which represent the informational or representational forms of ignorance that actually arises from deeper root causes. I'm using these three terms in the way in which they're used in behavioral decision research. Probability is a representation of ignorance due to the indeterminacy of a phenomenon, which results from the fundamental randomness or chaotic behavior of natural processes. Complexity is a representation of ignorance due to the intractability of a phenomenon, which results from features of the phenomenon that make it difficult to understand, such as multiplicity and interdependence. Ambiguity is a representation of ignorance due to the indeterminability of a phenomenon, which itself results from a lack of reliability, credibility, or adequacy of the evidence or information at hand. Uncertainty arising from any of these three sources, probability, complexity, and ambiguity, ultimately pertains to several specific substantive issues, and these issues can be divided further into broad categories of scientific, practical, and personal issues, which all comprise the second dimension of uncertainty. Scientific issues on the left-hand side of this figure are data-centered and include uncertainties about the diagnosis, prognosis, causal explanations, and treatment of a given health condition. While practical issues at the center of the figure are healthcare system-centered and include uncertainties about the structures and the processes of care and what one must do, for example, to access healthcare. Personal issues on the right-hand side of the figure are patient-centered and include psychosocial and existential uncertainties about a given health condition and its impact on one's life. Finally, uncertainty pertaining to any issue and arising from any source is ultimately located in the mind of one person or another, and this comprises the third dimension of uncertainty. In medicine, patients and clinicians are the main loci of uncertainty, although uncertainty is often not equally shared between them. For example, sometimes scientific uncertainties reside only in the minds of clinicians, while personal uncertainties reside only in the minds of patients. The goal of shared decision-making is to distribute these kinds of uncertainties more evenly between clinicians and patients. The next major aspect of uncertainty that I'm going to talk about are the effects of uncertainty. Specifically, what is its natural history? What psychological responses does uncertainty provoke in people? There are two main categories of responses to uncertainty. The primary response consists of well-described syndromes that represent people's initial psychological reactions to uncertainty. The secondary response consists of compensatory processes that people use to regulate their primary responses to uncertainty. I'll first talk about primary responses. Primary responses to uncertainty consist of three main syndromes that correspond to the three main types of uncertainty. Aversion to probability, or risk, consists of negative psychological responses to unknown outcomes. Aversion to ambiguity consists of negative responses to unknown versus known probabilities of outcomes. Complexity aversion consists of negative responses to more versus less complex information. These three syndromes have been well documented by a large body of research, and each consists of a common set of negative psychological responses. Cognitively, these responses include pessimistic appraisals, perceptions of vulnerability. Emotionally, they consist of fear and feelings of anxiety. Behaviorally, they consist of decision avoidance or deferral, or avoidance of information. And yet, not all responses to uncertainty are negative. Less studied but equally important are positive psychological responses to uncertainty. These include, from a cognitive standpoint, optimistic rather than pessimistic appraisals, as well as confidence. Emotionally, they consist of feelings of hope, or of solace, or reassurance. Behaviorally, they consist of decision-making and information-seeking. So the natural history of uncertainty is complex. It reflects a shifting balance or a dynamic equilibrium between different negative and positive psychological responses. The sum total of these responses at any given moment or situation for any given individual is an individual's uncertainty tolerance. This is a descriptive construct. It simply relates what an individual's current balance of negative and positive responses to uncertainty happens to be at a given moment in a given situation. This figure provides a visual depiction of this state of balance between different psychological responses, cognitive, emotional, behavioral, to the perception or experience of uncertainty. Uncertainty tolerance is a concept that signifies this momentary state, but it can also refer to a trait-level propensity towards a particular balance of responses. But in this talk, I'm really focusing on uncertainty tolerance as this state of balance between negative and positive psychological responses. I'll now turn to secondary responses to uncertainty. And these responses, again, consist of compensatory regulatory processes and strategies that people use to cope with their primary reactions to uncertainty. These regulatory strategies can be subdivided into four main categories. Ignorance-focused strategies aim to decrease knowledge deficits that are the cause of ignorance. Uncertainty-focused strategies aim to decrease or increase one's metacognitive awareness of ignorance, that is, one's uncertainty. Response-focused strategies aim to mitigate the aversive psychological effects of uncertainty. Relationship-focused strategies, finally, aim to distribute or share uncertainty between persons to broaden the locus of uncertainty. The first category of ignorance-focused strategies aim to acquire information and achieve knowledge. Specific ignorance-focused strategies consist of initiating diagnostic evaluations, tests that might be performed to clarify the diagnosis at hand, instituting therapeutic trials, consulting with colleagues, and searching the medical literature. The overall goal of these common strategies is curative. It aims to eliminate uncertainty. Uncertainty-focused strategies, in contrast, aim not to reduce ignorance, but to adjust or modify one's metacognitive awareness of it. These strategies include maximizing or minimizing attention to one's own ignorance, disengaging from uncertainty in various different ways, adjusting one's epistemic expectations, that is, how much knowledge one actually needs or will pursue, and also ordering uncertainty, organizing it in some ways, such as establishing rules or guidelines that can help bring some organizational structure to uncertainty. These different uncertainty-focused strategies are also curative in nature, but they aim not to eliminate ignorance, but to eliminate uncertainty itself. Response-focused strategies aim to mitigate aversive psychological reactions to uncertainty. These strategies include withstanding negative effects, that is, simply bearing with the fear or other negative psychological reactions that uncertainty elicits. Cultivating virtues consists of promoting key moral capacities that help manage uncertainty, such as thoroughness or due diligence. Compartmentalizing consists of dissociating oneself from specific negative reactions. Self-affirmation consists of acknowledging key values that provide meaning in one's life. And finally, self-forgiveness consists of the ability to exercise mercy and to let go of self-blame. The goal of all of these different response-focused strategies is palliative. It aims to ameliorate the suffering that uncertainty causes. Finally, relationship-focused strategies aim to share uncertainty between persons. These strategies include both sharing with colleagues and sharing with patients. The aim of these strategies is to share not only experiences and responses to uncertainty, but the responsibility for managing it. The goal of these strategies is also palliative. It aims to ameliorate the suffering that uncertainty causes. The last set of frameworks I will present focus on the management of uncertainty. Specifically, how should we go about evaluating and treating uncertainty and its effects? I've argued that uncertainty elicits both primary psychological responses, most of them negative or aversive, as well as secondary responses aimed at coping with these primary responses. These strategies are ignorance, uncertainty, response, and relationship focused. The key task in managing uncertainty is to enact the most appropriate regulatory strategies for a given individual and situation. The question is, how can we accomplish this task? I believe one promising answer is to evaluate and manage uncertainty in the same way that we approach other clinical problems, by establishing a diagnosis, assessing its prognosis, clarifying goals, and finally determining treatment. And these steps, I think, comprise a clinical approach to managing uncertainty that may be useful in practice. Establishing the diagnosis involves clarifying the source, issue, and locus of the uncertainties that arise in a given clinical situation. Assessing prognosis involves clarifying the extent to which these uncertainties are reducible or irreducible. Determining treatment involves clarifying which particular regulatory strategies, ignorance, uncertainty, response, or relationship focused, ought to be enacted in a given situation. Clarifying goals involves specifying the ultimate aims of managing uncertainty. Potential aims consist of cure or palliation, as we've discussed, but they also consist of the ultimate aim of uncertainty tolerance in a normative sense, which I'll discuss further. Now I want to turn to examples of how this clinical framework for the management of uncertainty might be applied to clinical genomics. Here's one attempt by investigators to establish the diagnosis of uncertainties in clinical genomics. Here the focus is on uncertainty regarding genetic testing for cancer susceptibility. The investigators broke down the existing uncertainties by source and issue, as well as locus, focusing on both genetic counselors and patients. Here's another effort by investigators to establish the diagnosis of uncertainties in clinical genomics. Here the focus is on parental uncertainty in response to an abnormal prenatal scan for fetal anomalies. These investigators broke down the existing uncertainties by both source and issue. A further step that might have been undertaken is to assess the prognosis of the specific uncertainties that are identified. For example, some of these uncertainties are reducible, at least in principle, through the acquisition of further information. Assessing the prognosis then helps to clarify the goals of managing uncertainty. For uncertainties that are reducible, the appropriate goal is curative as opposed to palliative. Assessing the prognosis and goals of managing uncertainty then allows the appropriate treatments to be determined. For reducible uncertainties where cure is the goal, ignorance-focused strategies are appropriate. These include things like initiating diagnostic evaluation, instituting a therapeutic trial, or consulting with colleagues, for example. The investigators in the previous example focused on these treatment strategies for managing uncertainty. They recommended providing clear and simple information, engaging with appropriate experts, and providing regular monitoring to parents, for example. Notably, all of these treatment strategies are largely ignorance-focused and aimed at curing uncertainty. And yet, not all uncertainties are reducible. Some of the uncertainties in the current case, for example, cannot be resolved, even with additional information. In cases like this, the management goal, therefore, is palliation rather than cure. And the appropriate treatment of these uncertainties encompasses a much broader range of palliative management strategies that focus not only on our ignorance, but on our uncertainty, our psychological responses to it, and our personal relationships. And yet, simply ascertaining whether a cure or palliation is a more appropriate goal for managing a given uncertainty is not sufficient to determine what specific treatment strategies should be undertaken for any given individual or situation. After all, there are many different combinations of both curative and palliative strategies that are both possible and appropriate for different individuals and situations. Furthermore, both negative and positive psychological responses can be adaptive or maladaptive, depending on the individual and situation. There's no single right or correct combination of strategies for managing any given uncertainty. Therefore, higher order ultimate goals are needed, specifically uncertainty tolerance in a normative sense of the capacity to achieve an adaptive balance in one's responses to uncertainty. This balance is specific to the individual and situation and needs to be defined by them. The key question is, how do we help individuals achieve uncertainty tolerance in this ultimate normative sense of adaptive balance? I believe that one part of this answer is to foster several key moral virtues or psychological capacities that help individuals transcend their uncertainty and to chart their own course for managing it. These moral virtues consist of humility, flexibility, and courage. Each of these virtues serves distinct functions. They enable individuals to transcend their uncertainty in different existential dimensions. Humility enables individuals to transcend their uncertainty in a metaphorically vertical direction, to rise above their uncertainty so that they can regulate it in the first place. Flexibility allows individuals to transcend their uncertainty in a metaphorically horizontal direction, to move across their own varying negative and positive primary and secondary responses to uncertainty, and to arrive at an adaptive combination of different responses. Courage helps people to transcend uncertainty in a forward dimension or direction, to move ahead and to take action in spite of their ignorance. The moral virtues of humility, flexibility, and courage are thus key instrumental goals in efforts to manage uncertainty. All of this is to say that the critical step in managing uncertainty is to clarify the goals of the endeavor, which consist not only of cure and palliation, but of tolerance in the normative sense of the capacity to achieve an adaptive balance in one's responses. And this capacity is enabled by the moral virtues of humility, flexibility, and courage. The task of managing uncertainty ultimately boils down to fostering these moral virtues among individuals, so that they themselves can determine what specific treatment approaches are most appropriate for them. In closing, what I've tried to do in this talk is to lay out a set of conceptual frameworks for understanding uncertainty in medicine, and to outline a systematic approach to managing uncertainty, both in medicine in general and clinical genomics in particular. I've argued that managing uncertainty is ultimately a higher order metacognitive endeavor consisting of the tertiary regulation of our responses to uncertainty. I've argued that a framework-guided, goal-driven approach to managing uncertainty can make this effort more intentional and effective. I finally argue that the ultimate goal of managing uncertainty is tolerance in the normative sense of the capacity to find an adaptive balance in one's responses to uncertainty, and that increasing this capacity requires fostering key moral virtues of humility, flexibility, and courage. These are not typical goals that guide medical care, but I believe they are essential in helping both patients and clinicians manage and tolerate uncertainty. More research, though, is needed to understand how to achieve these goals, both in clinical genomics and medicine in general. In the meantime, this framework, like all of our efforts to manage uncertainty, very much remains a work in progress. I'd like to thank you for your attention today, and also to invite any of you to feel free to email me if you have any questions or comments on this talk.